What physical therapists need to know about hip dysplasia. Okay, so why are we covering hip dysplasia? I think this quote says a lot about why we need to be talking about this and educating physical therapists about it. So essentially, this quote was the mean time from the onset of symptoms to the diagnosis of hip dysplasia was 61.5 months. The mean number of healthcare providers seen prior to the definitive diagnosis was 3.3. So essentially, if the patient has hip dysplasia, they're going to start seeing different providers because they have pain and disability related to it. It's going to take many years to get an accurate diagnosis and have to see a whole bunch of different specialists, right? This is obviously not good. And what I will say is that as a physical therapy student, I think they mentioned hip dysplasia. I didn't learn anything about treating it. I didn't know how to diagnose it. And over the course of time, I got a little bit better at diagnosing and treatment of FAI, which is potentially something that goes on with dysplasia. But dysplasia is a step further. And the problem is that if you don't address this well, it leads to hip osteoarthritis. And that's obviously not a good thing. And the other problem with hip dysplasia is it masquerades as a lot of other different pathologies. So you may think that someone has an adductor strain or a hip flexor strain. They're dealing with FAI or something along those lines, when in reality, they may have hip dysplasia. And for the majority of patients that I see, usually it's gone undiagnosed for far too long, and they end up with another procedure like a hip replacement surgery because they never got the right procedure or treatment earlier on. So it's not a good thing, right? I think basically we need to do a good job of diagnosing this and then treating it appropriately. Kevin, do you feel like you got good information about this in PT school to the point where you knew how to diagnose it and treat it?
No, definitely not. And those are pretty staggering numbers. And I think that, we need to do a better job as a profession, kind of doing a better job diagnosing these, because that's a long time to go with symptoms and not getting good answers for why you're having these symptoms. I mean, that's like 5 years, right? So definitely interested to see what you got here because no, didn't do a good job learning about this in school.
Yeah, when I saw the amount of months, I was like, I have to do math to figure out how many years that is because that's a lot of months, right? Yeah. So going on to what we're going to be covering today, we're going to go over hip dysplasia background, prevalence in populations, anatomy, risk factors, pathogenesis or the mechanism of injury, clinical examination, imaging, differential diagnosis, treatment, both non-operative and surgical management. Let's get rolling. So starting off with definition and background, acetabular dysplasia is defined as a structurally deficient acetabulum, both in shape and orientation, resulting in poor coverage of the femoral head, and is a well-recognized cause of hip pain in young adults, particularly women in sports like gymnastics. So essentially, this is characterized by poor acetabular coverage, which creates excessive wear on the acetabular articular cartilage and labrum and produces degenerative changes. So what you'll often see is folks have dysplasia with coexisting labral pathology and or coexisting hip osteoarthritis if it goes on for long enough. Without appropriate management, acetabular dysplasia can lead to severe pain and disability. Hey there. Do you like floppy hip joints? Of course you don't. Guess who else doesn't like floppy hips? Your patients. So that means you're going to have to know how to treat hip dysplasia. And I've got the solution for you. It's an evidence-based cheat sheet for the diagnosis and treatment of hip dysplasia. My promise to you is I'll catch you up to date on the latest evidence on hip dysplasia under 10 minutes. And we go over all the most important information, including definitions and background, prevalence and population, relevant anatomy and risk factors, pathogenesis and clinical presentation, physical examination and radiographic findings, injections, differential diagnosis, treatment, physical therapy, surgery, and lastly, return to sport. So this cheat sheet is 100% free. I will leave a link in the description for you to go ahead and download that. Happy learning. And now back to your video. What is the prevalence and population involved with hip dysplasia? In an adult population, around 5 to 12% of the general population has hip dysplasia. And we'll talk about what this means in a bit, but it's a big chunk of folks. It doesn't mean that everyone with hip dysplasia has pain. It just means that they have radiographic evidence of hip dysplasia. And the majority of these cases are borderline dysplasia. So it's not like everyone has severe dysplasia. It's just that there's a lot of folks there that have borderline dysplasia, and we'll define that in a minute. There's less folks that have more advanced dysplasia. Like I said, it's commonly asymptomatic. Beerle et al. In 2005 found that those with hip pain were more likely to present with dysplasia, and 32% of patients presenting with hip pain had radiographic evidence of dysplasia. So if I have hip pain, probably have a greater likelihood of having hip dysplasia, right? And Noguer et al. In 2010 found that 35% of a general population had radiographic evidence of dysplasia. So this was very interesting to me. I didn't realize how much asymptomatic dysplasia was out there, or just folks that have dysplasia. And that 35% number, that's very big, but usually this is in borderline dysplasia, and essentially treatment's going to be different from borderline dysplasia to more severe dysplasia. And it's also one of those critically reasoning thoughts that a surgeon goes through in terms of what's the best treatment for this patient that's in front of me. Let's talk about the relevant anatomy. And essentially, if you're watching the YouTube version of this, we have a femur and a pelvis. So on the pelvic side, you have the socket or the acetabulum. And on the femoral side, you have the ball or the femoral head. And then surrounding the femoral head and socket, you have the labrum, which is a ring of fibrocartilage that surrounds the acetabular rim. It forms a suction seal around the hip or gasket, which reduces shear and improves shock absorption. And damage to these structures may lead to and is associated with premature hip osteoarthritis. So the thought is, if I don't have good overcoverage of the socket over the ball over the course of time, this can lead to more damage of the labrum. Damage to the labrum will reduce the ability of the hip to tolerate these forces well, and that leads to more hip osteoarthritis over the course of time. We have another image here of a hip that's been cut in half, and you can see the acetabular labrum as it surrounds the hip joint, right? What's kind of cool is it does have synovial fluid on the inside of the joint, and that's contained via the labrum. So when we walk, we're actually walking on water, right? We have this layer of fluid, helps with shock absorption. And once you tear that labrum, we're no longer walking on water, a little more stress on that cartilage, right? This is a pretty cool set of images here on the left side. And if you guys are not watching this on YouTube, I'll try to describe it as best as possible. I do recommend checking out the YouTube version, the video version of this podcast to make sure that you can see. On the left side, you have a normal hip. And essentially, you have a blue line above the femoral head, below the pelvis. On the left side, in the normal hip, it's a larger blue line, right? And that's going to represent the amount of contact area between the femur and the acetabulum. And what you'll notice is that the acetabulum extends further out over top of the femoral head. On the right side, this blue line is a lot smaller. And what you'll notice is that the acetabulum does not go out as far over top of the femoral head, right? So what ends up happening is you have more stress in a smaller area. And that can lead to more labral pathology and obviously more cartilage pathology over the course of time. And you can also visualize well the shear that would occur on the hip joint on the right side. So because we don't have good overcoverage of the socket over top of that ball, when we take a step, it makes sense that that ball is going to shear a little bit more so and create more force within the hip joint over the course of time, right? So some risk factors for developing pain and labral pathology associated with dysplasia, because if you have dysplasia, doesn't mean you're automatically going to end up with pain or labral tear, are going to be things like a shallow acetabulum. So if I don't have good contact with the ball into the socket, that can create more issues. If I have excessive femoral anteversion, so essentially if the femur is facing more forward, this would also be referred to as antetorsion. If I have acetabular anteversion or retroversion, essentially now the socket is facing either more forward or backwards. That can also lead to problems. If I have an increased femoral neck shaft angle greater than about 140, also known as coxa valga. So if you're looking at the images here on the slides, coxa valga means that femoral neck is facing more upwards, right? If I'm coxa norma or coxa vera, I have that femoral neck facing more horizontally. So if I have the femoral neck facing more vertically, so greater than 140 degrees, that's going to increase more the shear force on the hip, right? Which may lead to more labral pathology over the course of time. If I have inferior acetabular insufficiency, so again, just don't have good overcoverage of the acetabulum over the femur, excuse me, that's going to create issues. And lastly, if I have poor coverage of the acetabulum over the femur, that creates a biomechanical disadvantage for the hip musculature. So essentially, my hip extensors, my hip abductors are not in a good biomechanical position to produce force because it changes the moment arm of the muscles. So now I can't control motion quite as well from a muscular standpoint. I don't have bony congruency to help to control those forces. And all these anatomical variations are going to result in insufficient femoral head coverage, leading to joint instability and increased risk of labral tears and early osteoarthritis. We are coming at this podcast fast, Kevin. What are your thoughts on all of this that I just spat at you?
Yeah, that was good. And I think what I was keeping in mind the whole time you were talking is how underdiagnosed this is, or how long it takes to diagnose. And it's just interesting because it seems like it's kind of the polar opposite of FAI, when we have maybe too much overgrowth of the acetabulum or the femoral neck, and we kind of get the cam and pincer type lesions. So, I think it is interesting. This is very different. And it was making me think about the shoulder a little bit. And the shoulder is a joint where we tend to see a lot of instability in certain folks. But I think what's easy about the shoulder is we can easily perform joint play, right? We can kind of get in there and easily assess range of motion. We can assess joint play and kind of get an appreciation for how much translation there is. I think part of the problem with the hip is it's not so easy to perform joint play on the hip. We can't get the same feel for how much translation there is. So, I think a lot of these things you're talking about rely on some imaging techniques to diagnose. But I think something we can listen in for is, do they feel, any subjective feelings of instability? Are their muscles strong enough around the hip to help support the hip in the socket? Have they had any subluxations or dislocations of their hip? Because I'm sure that will, probably create more damage and more things that we might need to worry about. So I guess trying to draw some parallels between the things that we seem to know a lot about, whether that's FAI or the shoulder and shoulder instability, and hopefully it can help us get a better grasp on the hip and hip dysplasia, so we can do a better job diagnosing these things and not having the patient go through so many hurdles and stuff to try to get a good proper diagnosis and a good management approach.
Yeah, you said a couple cool things there. One of which is talking a little bit about pincer morphology, right? So pincer morphology is the opposite of hip dysplasia. You're having excessive overcoverage. And if you look at some of the research on pincer morphology and rates of osteoarthritis, we know that cam morphology is going to correlate with more osteoarthritis over the course of time. Pincer does not. But if you have a pincer morphology, you actually have better bony congruence and more stability of the hip. So one of my thoughts there was initially like, oh, why doesn't pincer lead to more hip osteoarthritis? And then going through the research on dysplasia, I'm like, well, it promotes better congruence. It increases contact area of that femur. So maybe better, right? And the other thing that I was going to chat about is that we don't have great clinical tests for this quite yet. We do have some tests for micro instability, which is kind of like a new kid on the block in terms of a diagnosis for the hip. One of the challenges that surgeons have is that when you're looking at a hip and you're looking at images, right? So let's say someone has borderline dysplasia, so it's not that bad. The thought is, do we need to do a PAO procedure, which is very invasive, or can we just repair the labrum, right? And one of the thoughts is, well, we know that there's a little bit of undercoverage from the bony structures, but what's the deal with the ligaments? Are they loose? And it's challenging for us to tell that. And we do have some tests for micro instability, which I'm actually going to make a video of at some point. I'm going to do a video on diagnosing hip dysplasia where I go over all those tests. I'll briefly mention some of those, but you'll see them more in depth later. That's challenging, right? If you have a patient with borderline dysplasia but has solid ligaments, then they do pretty well, which we'll talk about a little bit later with just a labral repair. But if they have a little bit of dysplasia, but they're also very loose, right? So they have a lot of laxity via like Baden scale or some of these micro instability tests, then maybe we do need to stabilize them a little bit better with that PAO. And even at Children's Hospital, and this is a test that's not done nationally as far as I know, but Children's Hospital in Boston, they'll do a dynamic ultrasound test where they basically take the patient, lay them on their back, have their leg off the table, they go on end range extension, and they'll look at the hip and they'll see, is it sliding a lot, right? Which is a test to see if there's ligamentous laxity. And they'll do the same. They take them in end range flexion and they'll see if there's a whole lot of motion at the ball and socket joint. And they actually will use that as a test to determine whether or not someone can get a hip labral repair or they need to get something more invasive like a PAO, which is kind of like what we see at the shoulder. If someone has a lot of instability, maybe we need to go straight to that Lateral procedure, which gives you a lot of bony congruence. And if someone is not that unstable, maybe a Bankart repair works out pretty well. But it is funny just seeing the history because we have a lot more time looking at shoulder instability, a lot less time looking at hip microinstability. It's kind of like a newer diagnosis, but you can kind of draw those parallels if you have some background with the shoulder, kind of makes sense with the hip. So moving on. So we're not recording all day long and Kevin can get to his activities. What are some risk factors for acquiring hip dysplasia? And this is symptomatic hip dysplasia. So one, female sex. And the thought is that there are differences in pelvic anatomy, which we just talked about previously, as well as ligamentous laxity, particularly if someone's pregnant, right? Around pregnancy, obviously there's changes in ligamentous laxity. And that could lead to some issues with dysplasia, right? Symptomatic dysplasia. It typically occurs with young active women. So if you look at, let's say, dancers, ballet, gymnasts, so essentially in sports where you have women working towards end ranges of motion at the hip, there's a propensity for that to become symptomatic over the course of time. This is also more common in folks who have generalized joint hypermobility. So think about your patients with Ehlers-Danlos or just general joint laxity measured via things like a Baton scale. And there's also another subjective measure, which I'll talk about a little bit later, that does do a pretty good job of diagnosing these folks that have generalized joint hypermobility. Developmental factors are also going to be relevant. Breech presentation, so being born in the opposite direction, right, with the feet first as opposed to the head first. Oligohydramniosis. Whew. First time that I ever learned about this, had to actually look this up. So being born with too little amniotic fluid, so essentially during pregnancy, not having enough amniotic fluid, as well as a family history of developmental dysplasia. So developmental dysplasia is not the same thing as dysplasia in adulthood. Although if you have developmental dysplasia, it does increase the likelihood of having symptomatic dysplasia as an adult. And having a family history of this also increases your risk into adulthood. And then the severity of dysplasia, which is going to be measured via the lateral center edge angle. We'll talk about that in a minute, and the presence of a labral tear are early predictors of hip osteoarthritis. So this goes back to our earlier point. If we have a patient where you're thinking they may have hip dysplasia, right, and or a hip labral tear, because what's probably giving the patient problems is not the dysplasia itself, or at least pain. It's probably that associated irritation that's occurring around the hip joint with potential damage of that labrum. So if you have a patient that comes in and it looks like they have labral pathology, we have to do our due diligence of figuring out, is that from cam morphology? Is that from dysplasia, right? Because the treatments are going to be a little bit different. Moving on to pathogenesis of hip dysplasia. So we talked about this before. We'll briefly review it. So if we have acetabular undercoverage, that's going to increase shear forces on the acetabulum and labrum. This was a really cool stat. So the labrum normally attenuates 1 to 2% of joint loads in a normal hip. For folks that have acetabular dysplasia, the labrum attenuates 4 to 11% of total joint loads. So you can see when someone has dysplasia, that labrum is under a lot of additional stress, and that's going to increase anterior superior loading. Like we said before, hip dysplasia is a leading precursor to osteoarthritis. Another really cool stat, hip dysplasia is seen in 20 to 40% of patients with hip osteoarthritis. So we said before, general population, around 5 to 12% of those folks have dysplasia. in folks that have symptomatic hip osteoarthritis, 20 to 40% of those folks have dysplasia. So it does seem like folks are getting more hip osteoarthritis when they have dysplasia. So an increase in mechanical stress on the cartilage matrix with failure of the acetabular labrum represents the major pathomechanism of degeneration. I'm going to let Kevin speak a little bit here. Anything to add, Kevin?
Yeah, I think that's, another parallel I guess we could draw with the shoulder is that it does seem like that micro instability over the course of time is probably not great for the health of the joint. And then I was just thinking, I've never really thought about this because I haven't thought about hip dysplasia a ton. But I know very anecdotal, but my mom had an early hip replacement. I think she was in her 40s or early 50s at the time, and not a super athlete by any means, and no trauma history in her hip, but very hypermobile as a person. And I'm just wondering, sitting here thinking, listening to you, if she had undiagnosed hip dysplasia. So I do think that's possible. And then, one thing that you said that I think is important to keep in mind, and this is, a saying that you love, I hear you say this a lot, is when you hear hooves, think horses, not zebras, right? So when you do have a young, perhaps female dancer or gymnast in PT with hip pain, perhaps with that population, you want to start thinking about hip dysplasia as a primary diagnosis, and not, maybe in that population, the more restrictive range of motion FAI type thing. So I do think you don't want to go in so confident that it's this thing because you have a female gymnast. But I think it's very, you want to go in with this, at least in your mind. It's like if you see a baseball player with elbow pain, you kind of want to go in thinking, I got to rule out the UCL. I got to rule out a flexor pronator muscle strain. You're not thinking of some crazy thing that is probably like, this might not be, elbow arthritis or something like that. I think that's a good lens to go into this type of treatment or evaluation with is let's see if this has clinical signs of hip dysplasia. Maybe you could be the first provider they see that could kind of hone in on that diagnosis. So I think when you have the population in front of you where it's so common, go into it with that mindset until it's kind of proven otherwise.
Yeah, two things. One, my mom had a hip replacement when she was 35.
Wow.
Didn't know that your mom had a hip replacement early.
Yeah.
And my second thought is that, and I've looking back on my, 10 plus years, whatever, of treating patients and thinking about the labral tear patients I've treated over the course of time. I've had, as PTs, we have direct access and people get better over the course of time and they never get imaging. So you really know what's going on inside the hip. I've had a few patients, particularly runners, where they had what seemed to be a hip labral tear. And, looking back on it, I was like, I hope they didn't have a femoral, neck stress fracture. But B, they may have had dysplasia too. And they got better, right? And some didn't. Like I've had some runners that didn't get better and then went on to get PAO surgery, right? Because they had dysplasia. But I wonder if my diagnosis of hip labral tear was potentially accurate, but they had underlying dysplasia as well. Mm-hmm. So going back in my Rolodex of like patients in the past, reading through a lot of this research makes me think like maybe there is a lot more hip dysplasia that I just didn't realize, just because that mechanism of injury for, let's say, a large cam morphology is a lot of flexion and rotation. For runner, they're just going into a little bit of hip flexion and extension, right? Like that shouldn't create a labral tear with cam morphology. The mechanism of injury doesn't really make sense. So that just gets me thinking, right? So if we're trying to differentiate between the two types of pathologies, maybe it does come down to that mechanism of injury, right? And also the population, so on and so forth. So it just got my brain thinking a little bit more, which I think is good for critical reasoning when you're trying to determine what type of patient you're dealing with. So I thought that was good stuff, Kevin. All right, clinical presentation. When you have a patient that's coming through the door that potentially has hip dysplasia, what are they saying? What do they present as? And this was a cool study. This was in the Journal of Bone and Joint Surgery, 2011 paper, oldie but a goodie. Clinical presentation of symptomatic acetabular dysplasia in skeletally mature patients. The participants in this study, they had 41 females. That was 72% of the population. In 16 males, 28%. So kind of the split you would expect, more females. The mean age was 24. So again, young. And what I think was important here was that all of these participants were treated with PAO. So
Right.
peri-acetabular osteotomy. Oh my gosh, what a mouthful, right? And this is important because essentially we know that these folks had hip dysplasia, or we really think so because we were so certain that we gave them surgery for them, right? But then they had an opportunity to see what these patients were saying at the initial presentation, right? And 97% of these patients had an insidious onset. What that means is it's a slow onset of symptoms. It starts very gradually and just ramps up over the course of time. They didn't have trauma, right? So it's not like this is a group of patients that had trauma and then they go into the doctor and like, oh, you've got hip dysplasia, right? This is usually insidious. 77% were associated with moderate to severe pain on a daily basis. So it hurts a lot, right? These are patients that hurt a lot, and it hurts with regular activities. It's not just sports activities, which I think is a little bit of a differentiator between folks that have FAI, right? That was one of my first thoughts. Pain was most commonly localized to the groin, 72% of patients, and or the lateral aspect of the hip, 66% of patients. And I guess two thoughts there. A, presents very similar to hip labral tears in folks who have FAI, but that percentage of folks with lateral pain was a little high to me. So who knows? I wonder if other future studies will show similar results there, but that was kind of high, I thought. 88% had activity-related pain, so essentially it hurts to do activities. This makes sense. 75% of the cases, activity restriction diminished their pain. So if they just stayed away from the activities that typically bother it, felt better, which makes sense. That most, I think, orthopedic issues, that's the case. 48% of patients presented with a limp, which I thought was interesting. So if I think about FAI, which is one of the biggest differential diagnoses, it doesn't always present with a limp, but it seems like for these folks, half of those patients did have a limp, which if someone's going in for surgery of anything, chances are it's more severe. So it does kind of make sense to me. But that's one of my thoughts. Like, okay, if someone has a major limp, that might be related to dysplasia. 38% had a positive Trendelenburg sign. So if you haven't stand on one leg, they present with a little bit of hip drop there. And 97% had a positive impingement sign. And that was basically a failure test, right? So if someone has a positive failure, could represent labral pathology, could represent someone that has dysplasia. Do keep in mind that when folks have dysplasia that's symptomatic, oftentimes they have associated hip labral pathology, which is going to be the same thing for FAI, right? So when someone has labral pathology, like the main factor could be FAI or it could be dysplasia. So that's the reason why those patients present very similarly. And when they have pain, it's probably the labrum, but what caused that labral tear is a little bit different in both those cases. And again, just to repeat, this quote did come from this study. The mean time from the onset of symptoms to the diagnosis of hip dysplasia was 61.5 months. The mean number of healthcare providers seen prior to the definitive diagnosis was 3.3. So that's a problem because if you've got dysplasia, undiagnosed, symptomatic, that's potentially leading to more hip osteoarthritis. And spoiler alert, if you have too much hip osteoarthritis, then a PAO procedure or a labral repair is not very effective. So if these go undiagnosed for long enough, they turn into arthritis. And then the only option for these folks is going to be a joint replacement, which is unfortunate. And this is one of the reasons why having good diagnosis early on is imperative for physical therapists, right? So moving on, more clinical presentation. When patients come in, they say they have pain. What does that pain feel like? Usually it's deep and aching. If I have a tendinopathy or strain, usually I can kind of put my finger right on where that pain is. Hip dysplasia, not always the case. It's usually kind of deep within that hip joint somewhere. It's worse with activity and improves with rest. It's generally in the groin, although, like we said previously, it can radiate laterally. Sometimes these patients have symptoms of instability, which is going to be a major differentiator between folks that have dysplasia and folks that have FAI, right? And particularly, this is going to be at end range. So you will see some micro instability tests. And I'm going to do a video on this where they basically have a patient in a Tonnis test position. And then from here, you can kind of scour the hip. We had spoken about these tests in our FAI talk previously. One particular test is you put the patient into a Thomas test position, and then you go into end range external rotation, which drives the hip anteriorly. And if the patient perceives instability, that's a positive special test for dysplasia and micro instability, right? But this might be one of those differentiators between I have a patient that has a primary diagnosis of dysplasia versus a primary diagnosis of femoral acetabular impingement. And the last piece is mechanical symptoms. We know these are common in labral pathology. So these patients may say they have snapping, locking, and catching. Again, this just indicates potential labral pathology. And Kevin, I'll let you talk. I saw you scrolling down some notes there. Anything to add at this point?
Yeah, just when you were going over the symptoms, I was trying to think of how those are different from what you might see with someone with like a femoral neck stress fracture, and they actually look very similar. But I think what might be different is the history, like an insidious onset in both cases, but maybe with a femoral neck stress fracture, it's accompanied by a lot of bouts of long distance running or a lot of impacts. I have to talk to Dave about this, but I'm not sure gymnasts get femoral neck stress fractures. I mean, I'm sure it happens. There's probably in that cohort some, energy intake issues that might lend to that. So that's something I just not want to miss. But then I'm thinking if you do refer them for imaging to rule out the stress fracture, do they know to look at these hip angles to diagnose dysplasia? Or are they just going to look at it and say, well, you don't have a stress fracture, you're good to go. And then you're still left not knowing exactly what's going on from a diagnostic standpoint. So, but yeah, they do at least seem unique enough that it is different, perhaps than an FAI diagnosis. But yeah, I think those were good things to keep in mind. And I think something like you said, over 50% limp, and that's really interesting. That, like you said, that's different than FAI. You don't tend to see that unless it's like really, really flared up, like pretty acutely, but that doesn't tend to last so long, that acute flare up. So yeah, that's interesting. And hopefully we get better clinical tests for diagnosing in the clinic, because I'd hate to send someone for imaging for like a bone stress injury, and then have them come back and we still don't really know why they're having that much pain. So I guess you'd have to send them to someone who's good at looking at hips and someone who knows these angles to look at, so then they can do a better job with the diagnosis. So yeah, it's good. It definitely makes you think.
Yeah, it really underscores the importance of having to have really good doctors around you. You
Mhm.
already mentioned this, but I want to say, so Chris Johnson, like a friend of ours, he's like a running specific physical therapist. Never heard of him. Definitely check him out if you haven't. He has great information. That's where the majority of my running knowledge comes from. But he recently had a case study on his Instagram where he had a runner that he thought had a bone stress injury in the hip. And he gave him a pair of crutches and said, you need to get some imaging right away. Sends him to the doctor. Doctor says, you're fine. Doesn't want to order any imaging, right? Now, I had a friend of mine who, and I'd probably said this story before, but he had pain in his hip and he's a runner. And he looked very much like he had some labral pathology, right? And he had an appointment to go see a hip specialist and get some imaging. And he was gardening. He stopped running and he fractured his hip while he was gardening, right? And then he had to get, rods placed in his hip, and it was an emergency situation, right? It's not good. So it just really underscores the importance of fully understanding what you're dealing with and sending to the right doctors. And unfortunately, these three pathologies, I think, are very important to know how to differentially diagnose, because they all present very similarly. And at least one of these has some pretty dire circumstances if you tell folks to do the wrong thing, right? So it's just hard, unfortunately. And I wish we had some better ways of diagnosing it, but maybe it's kind of like a scaphoid fracture, where if someone comes in and they've got some wrist pain, right? And we're like, oh, it's a little tentative palpation there. We know that's not a very good specific test, but it's pretty dang specific. You need some imaging. You look like you might have a bone stress fracture. And as far as we know, you've got a bone stress fracture until we know otherwise, unless it's like super obvious that it's not. But I think in most cases, it's really tough to tell, right? So if we want to be safest, we probably do need to send to the right doctor who's not going to say, you're fine, you don't need more imaging, because we know you might not be fine. You might fracture your hip, right?
Mm.
And I know that, you said this before, zebras or horses, it's probably a horse, but in the case of a zebra, you just missed something that was really important, right?
Mm.
So tough. It's one of the tougher things I think clinicians are faced with, but important to understand, right?
Yeah. One thing I'll just say real quick is I know, having listened to Chris so much, is what he would say is in that population of runners, if they present with acute hip pain, um, and it's, I think, why he gave that patient crutches. You assume it's a femoral neck stress fracture until proven otherwise. But maybe in different populations, we don't think the exact same way. So, I think the population matters. So I would still think if you have a runner with acute hip pain, and they're running, running high mileage or whatever, it's probably because you said it could have dire consequences, right? So that's one where you don't want to miss it. I guess you'd rather order unnecessary imaging that comes back clear than, play around with it and something bad happens. So yeah, not an easy decision making thing, but that's why we're PTs. It's fun to try to figure that out.
Yeah, just like hope that you don't have a patient that fractures their hip, right? Over the course of
Yeah.
time.
Yeah.
All right, moving on to physical examination. So we already spoke about this, but gait is definitely something you want to look at. Essentially, we're looking for a variety of different things. The first one's going to be a Trendelenburg. This is my own personal opinion, having watched a lot of hips over the course of time. When I was in PT school, I was taught that Trendelenburg is something you see a lot of. And based on the stats in this paper, it seems like there's a high likelihood that you'll see a Trendelenburg. But I find that most folks, when they present with hip pain, right, or a weak hip, they don't Trendelenburg. They kind of do the opposite. They lurch to the side. If you've got really painful hip, loading that hip, then the thought is you might drop into hip adduction. And essentially, if you go to end range hip adduction, you get contact of the ball against the socket and it stops that range of motion from occurring. But in someone who has a painful pathologic hip, dropping into end range hip adduction kind of hurts. And if they have painful musculature on the side of the hip, then usually what they try to do is offload it. And they'll kind of limp to the side. So you'll see them lurch their trunk over to the side. I call it an abduction lurch. I don't know where I heard that from, but it kind of makes sense to me, right? Or they may present with a short stride and limited hip extension. So see these folks, when they take a stride, they don't like to extend the hip, maybe because they're unstable or painful when they stretch the front portion of the hip. So you may see a limited stride on one side, and maybe they are a little less upright when they come to terminal hip extension there, right? But I think any type of gait where it just looks a little bit off, if there's a little bit of a limp there, it's a sign that they might be dealing with some hip dysplasia, right? Next, range of motion is really important to look at, and kind of going through these hints. This is a nice way to differential diagnose between someone who has more just generic FAI with a cam morphology. So first, you may find that they're a hypermobile athlete, right? So it would be a good idea to check a Baton scale. And again, we'll go through the Baton scale a little bit more in the future videos. Or there's another intake form that I wasn't really aware of until I saw it doing a literature review for this lesson today. I'm going to say it wrong probably, but the Hakim Graham or Grahami score. Have you heard this before, Kevin?
I haven't, no.
So it's actually pretty well validated and very accurate. Like it had pretty good validity. Essentially, it's a 5-question questionnaire, and it tells whether or not a patient has hypermobility, right? So if you have a patient that has a positive Baton score, or they have this positive Hakim-Graham score, there's a chance they have general hypermobility. And now you might be looking at more of a patient with dysplasia over someone who has cam morphology. Because here's the thing, if you have someone who has a big cam morphology or a lot of pincer morphology, they lose range of motion. It's very common for them to have very limited internal rotation or hip flexion because of that morphology. If someone has labral pathology due to dysplasia, oftentimes have hip hypermobility. So you may find that they have pain at end range flexion or internal rotation. And they may even be limited with hip flexion, internal rotation, but it's more due to pain, right? So you'll see a hypermobile hip It's not limited with flexion or internal rotation, but just hurts a lot, right? And if folks have big cam morphology, they have a limited range of motion with pain and also that bony restriction too, right? And what you may find is they have hypermobile hips. And I think one of the tells is that they may have hypermobile hips on both sides, because if you're looking at a hypermobile athlete, they're probably going to have hypermobility on both side hips. So you might start to think this person may have more dysplasia and not necessarily your typical FAI, right? So that's one of the differentiators. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we'd like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning. Now, this is when we get into the actual diagnosis. So if you have a patient and you think they do have dysplasia and you send them to the doctor, they're going to order imaging and probably a variety of different types of imaging. But the most common is going to be X-ray images, and they're going to look at lateral center edge angle. And this is the most common way of telling if a patient has dysplasia or not. We went over this briefly in our talks on folks that have CAM, pincer, and FAI. But it's going to be even more relevant for folks with dysplasia. And essentially, you draw a vertical line from the center of the femoral head. The line is going to go towards the rim of the acetabulum. And if you have a larger angle, that means you have more over coverage. And if you have 40 degrees or greater, that indicates pincer morphology. But as the angle gets smaller and smaller, indicates more and more dysplasia. So if you're under 25 degrees, so between 25 and 20, that indicates borderline dysplasia. So it's not that bad. And that's important because it's going to dictate what we do from a surgical perspective. If you're between 26 and 40, that's normal. And again, over 40 is pincer. But if you're under 20 degrees, that's going to be more frank or more severe dysplasia. And that's what they tend to call it in the medical literature. So you have someone that's going to be under 20. There's less folks in the general population that have this. There's going to be more that are in that borderline between 20 and 25. And the reason why this is relevant is if you have someone that's between 20 and 25, and I have a patient right now that has this, and essentially she didn't get a PAO. She got a labral repair with a cam reduction, but she had a very small cam morphology and borderline dysplasia. And the thought was, hey, do we need to do a PAO or should we go ahead and just repair the labrum? And they didn't do a PAO. They just repaired the labrum, and she did really well. but she also went to Children's where they did that dynamic ultrasound test too, which was pretty stable, which is interesting. That was a differential diagnosis for that patient, right? Now, next I want to talk about a posterior center edge angle and an anterior center edge angle. Here's where it gets a little bit complicated. So laterally, you may have under coverage of the pelvis over top of the femoral head, right? But you can also have under coverage posteriorly or anteriorly. So if someone has a fine lateral center edge angle, they may still have under coverage anteriorly or posteriorly. So it makes things a little bit more complicated. And it's a reason why you need to have a really good hip surgeon who can look at all these angles and then make a decision. And the other piece is that when folks have surgical correction of this under coverage, they can correct this with a PAO procedure. So they can correct the lateral under coverage and or any anterior or posterior under coverage as well. So it's just important that the surgeon is looking out for all these things. And again, the reason why you need to have really good surgeons. And I'm pretty confident in the local surgeons that we have. I think they're really good. And what's funny is that one of the surgeons locally is a friend of mine. And I didn't realize this, but his name is in a bunch of the papers I referenced today, which is always cool to see, right? But I was like, I know that guy. Yeah. The other angle you'll see is the Tonnis angle. And this is a horizontal line from the medial border of the acetabular sorsal, which you don't really need to know what these things are, but you should probably know a little bit about what the Tonnis angle is. And then you have another line to the rim of the acetabulum, which goes to the lateral sorsal. And the sorsal represents a weight-bearing portion of the hip, right? So essentially, we talked about this before. If I have, and I showed that in the images of the 2 slides earlier. So if I have a really small sorsal, it means I don't have really good over coverage of the acetabulum over the femur. If I have a really large sorsal, it means I have a lot of contact area and a very stable joint. So essentially what the Tonnis angle is showing is how much contact area I have. So if I have very little contact area, more stress on a smaller area, potentially more shear forces, so on and so forth, right? And these Tonnis angles, if you're less than a 0, you've got over coverage, and that represents pincer morphology. If you're 0 to 10, that's normal, and greater than 10 represents hip dysplasia. And since we're moving on to something different next, do you have anything else to add, Kevin?
No, yeah, that's all good. And I just echo, like you said, I know you developed a good relationship with a good hip doc in the area that we kind of utilize at Champion, but it is nice to have someone who can read these images and kind of decide on the best treatment approach based on them. Because I could see a scenario where maybe that, like you said, that lateral center edge angle is normal, but they're not maybe looking at the anterior or posterior angle, and that could be a little bit not enough coverage there, and it could lend to some issues. So, I think, like you said, as physical therapists, it's good for us to know these. If we see the report and they report on, the center edge angle, it'd be good to know as, just good information. And we can kind of make sure they're getting the best treatment approach based on that. But it's really the job of the radiologist or the hip surgeon who's doing the imaging and reading these images to get these numbers for patients, so we kind of have the best treatment approaches. So yeah, I would just echo what you said, is that I think a specialized doctor for these cases is probably warranted.
Yeah, doctors are not evil. We need to have them in our network, and they're very good at their job, and they're important. So there you go. All right. Moving on to MRIs and MRAs. So I think this gets a little bit complicated. Just keep in mind, when someone has hip dysplasia, doesn't mean they're going to have pain. It just means they're more likely to acquire labral pathology as well as hip osteoarthritis. So when they become symptomatic, they potentially have labral pathology and arthritis, right? And the thing is, we need to have good tests to be able to rule in whether or not someone has labral pathology. So an X-ray is really good at looking at dysplasia, but it's not very good at looking at labral pathology. So we need to make sure that we have MRIs and MRAs with X-rays to try to figure this all out, right? And what's important is an MRI by itself is not very good at picking up labral pathology. We need an MRI with contrast, right? We talked about this in our FAI series, but essentially, if you don't inject dye within the hip and then you get an MRI, you may miss a labral tear. And unfortunately, I've seen this happen to a few patients now. It's just really important that you have good hip doctors that aren't missing this. I even had a patient that had hip surgery for debridement of his hip flexors because I guess they found a little bit of tendinopathy on his rectus femoris, right? And missed a big old labral tear just because they ordered an MRI. And based on that MRI, they went ahead and did surgery, right? And I guess because of the approach of the surgery, they never visualized the hip joint and they didn't basically see that labral tear and eventually went on to get a labral repair, which is the right surgery, right? So with an MRI, we can see a lot more than with an X-ray. So essentially, we can see the labrum, we can see cartilage, we can see that osseous morphology. So you can pick up on cam, pincer, you can pick up on dysplasia with these. We can also look at subchondral bone marrow, so we can pick up on hip osteoarthritis. We can look at the ligamentum teres, capsule, psoas tendon, glute medius, minimus, hamstring tendons, and rectus femoris tendons. So essentially, we can pick up on all sorts of other pathologies that may be coexisting. When someone has a bunch of lateral hip pain, that could be hip dysplasia, could be labral pathology, could be gluteal tendinopathy. So an MRI is actually pretty good for differential diagnosis as well. And it's probably important that we're ordering the right images when the patient goes to see the doctor. Again, all the more reason to send to good doctors who understand this stuff really well, right? How do corticosteroid injections fit into the mix here, right? So we talked about this in our FAI lecture. This is actually the same exact slide, but we can use it as a diagnosis criteria for hip labral pathology. So when you inject a hip that potentially has a labral issue, does it help you with your pain? If it does, that rules in that it might be labral pathology that's causing the issue. But the other piece is that it doesn't rule in why that person had a labral tear. Does this person have cam morphology or do they have hip dysplasia? We're not really sure yet, right? What I will say is that the injection is pretty good as a diagnostic criteria, but also good from a treatment perspective. We kind of reviewed that study by Pennock et al. That showed that around 70% of patients got better with physical therapy with FAI, and then additional 10% of patients or so went on to get an injection and did really well and didn't need surgery because of that injection. So I do think it can be helpful to help reduce pain if folks have labral pathology. But keep in mind, it's kind of short-term in nature. An excess reliance on corticosteroid injections can actually deteriorate the hip. So it's not a good thing to do long-term, obviously, right? But it does kind of become a player as a physical therapist. If a patient is not getting better, corticosteroid injection can tip them over the edge and cause some good progress from that standpoint. It's not just a short-term solution, I'd say. All right. Next, we move on to differential diagnosis. I think the job of a physical therapist, one of the most important jobs of a physical therapist, is just to make sure you're not dealing with any red flags, right? Is there infection? Is there a tumor? Is there a fracture, right? Talking about that bone stress injury previously. Fractures and tumors are recognizable with x-rays, CT scans, and MRI. Septic arthritis, osteomyelitis, or soft tissue infections will typically present with acute pain, inability to bear weight, and fever, right? So every once in a while, you get these head scratchers. Mike Reinhold talks about it all the time. I recently had someone who had pain in their shoulder, but it was kind of an odd spot, right? Didn't know what was going on. We kind of treated it a little bit orthopedically, but then I told him to go see his doctor. He actually didn't come back. I ended up calling him, and he had an infection in his lung, right in the top portion of his lung. And it was a head scratcher. I was like, well, this could be a variety of orthopedic issues, but just presents a little oddly, right? And if that's the case, send them out to the doctor because sometimes it is odd. Sometimes it is weird. Best case scenario, it's nothing, but if it's a head scratcher, then send them out. And for these issues, labs will help to distinguish between infectious cases, right? We're about to move on to some more common differential diagnosis, which I think is another talk. So before we move on, is there anything you wanted to add, Kevin?
Yeah, I think that last point you made is a good point. I think the more experience I get as a PT, I feel less hesitant to admit when something doesn't add up and you kind of refer somebody for imaging or just a second opinion with a doc because you don't want to miss those things. And when you explain your thought process to the patient, they're usually very receptive to it. And like you said, I think as physical therapists, we want to be the ones that people come to see first. You know, if you have hip pain, I want people to go see us first, that, you know, rather than go to their primary care or go to the orthopedic. So we should be the ones that can kind of help make those calls. And we can't do that if we're afraid to refer people and feel like we have to be able to fix everything. So there are times where it doesn't add up. We know that, hip dysplasia seems to be a very mechanical thing, right? It hurts with certain movements. It's movement dependent, like most things that we treat in physical therapy. So if it is something that's not adding up, don't hesitate to refer out. You want to make sure that you're doing the best thing for the patient. And I think the more we do that, the more other professions and patients realize that we are the ones who they can go see first when they have what seems like an orthopedic problem. And we can help be the ones to determine if it is. And if it's not, who do we send them to? So I think that's always important to talk about. And just, we should keep getting better at that so we get the respect of the medical community to be those people who are like the first line providers.
Yeah, it's funny, and I'm trying to think of the reason why even, but early on in my career, I felt bad referring out, and I think the big thing is like, oh, I'm forcing this patient to see another physician when it's probably nothing, right? But a lot of the probably nothings are like, oh, you have a fracture, or you might have a DVT, right? So it's just important that we refer out. And I, like you, have gotten more comfortable telling patients this over the course of time. Worst case scenario, you just don't want to miss something that's big. I had a patient recently, and this is not the hip, but I see a lot of patients with wrist pain. I work with a lot of folks that do CrossFit, Olympic weightlifting. There's a lot of weight bearing on a extended wrist, and wrist pain is very common in those folks, right? And they oftentimes will have tenderness on the scaphoid and the lunate. So over and over again, I'm always telling patients like, yeah, you probably need to get some imaging here. You might have a broken bone. And it's very rare, but I had a patient recently where he had a scapholunate tear and a large TFCC tear as well. And I would have had no idea if I didn't refer to get some imaging. Now, we're still trying to treat him conservatively. He's actually doing fairly well, but you do get additional information that's sometimes very, very relevant and important to know, right? So I wouldn't be fearful of it. It does sometimes make the situation a little more complex, but last thing you want to do is give a worse long-term outcome because you don't want to potentially, I don't know, feel more stupid or that you can't help someone or basically frustrate the patient with another doctor's visit, right?
Yeah.
All those things.
And I'll say quick, this week I had one where, I had a kid who had anterior hip pain. It seemed to happen on one moment. He was playing flag football. He was sprinting, sharp anterior hip pain. He's like 15 years old. And I was worried about an apophysitis injury. So I just talked to the mom and told her, like, hey, based on how he looks right now, I feel like I can't rule it out. I think it's probably best to get an x-ray just to see if this is what's going on. And it turns out that it wasn't that. So I still feel comfortable with my decision of recommending that because that would change the treatment approach for sure. And you don't want to miss that. And I had no good reason not to do it. And I think the mom was appreciative of it. And she was like, oh, yeah, this seems like something we don't want to miss. So in that case, it's easy. It's a simple x-ray. And so that was good. And I think earlier in my career, you feel bad. Like you said, you don't want to make them see someone else and you don't want to be wrong. Like if you're sending someone, I guess it feels good if the diagnosis is right for what you were thinking, but you just realize you're just trying to do what's best for the patient, and it's okay to not, to send them what seems like unnecessarily, but we want to make sure we're okay to load somebody and progress a treatment program. So I think with a lot of things in hip dysplasia included, if it seems like it might be something else that that won't allow us to progress, you don't want to do the wrong thing and end up in a way worse spot because you didn't want to refer someone. So yeah, it's okay to refer someone and be wrong.
Yeah, for sure. Good point. All right, next we're going to talk a little about differential diagnosis. And I think this is probably one of the most important parts of this lesson today. Although we probably went over most of this, which I think is good, right? But you've seen those stats. The stats are the same in FAI as they are with hip dysplasia. We're terrible at diagnosing these things, and it comes at a big disservice to our patients. So we need to get better at diagnosing not just dysplasia, but everything else. So I want to talk through this differential diagnosis and hopefully give you some good clinical pearls. So when these folks present to us, they do look a lot like labral pathology, which could be coming from FAI, could be coming from dysplasia. But one of the biggest, I would say, misdiagnoses is going to be labeling these folks as having a hip flexor or an adductor strain or having tendinopathy, right? Now, one of the giveaways I'd say with dysplasia compared to a strain is that a strain tends to be traumatic, right? So if you have an athlete that strains a hip flexor and adductor, usually happens all at once. And when you have someone with dysplasia, that's going to be more insidious, like we talked about, right? But for some of these chronic issues, so a hip flexor tendinopathy or an adductor tendinopathy could be more chronic, right? What I will say is that usually there's more tenderness to palpation, either directly over that tendon. In the case of the psoas, it's a little tough to palpate, but you can palpate it right underneath of the inguinal canal on the hip, and that's super tender to palpation. Could be a sign they're dealing with more of an adductor tendinopathy. But what I will say is that pain with resistant hip flexion could be indicative of labral pathology, but usually with tendinopathy, you can put your finger right on the area. For dysplasia or labral pathology, usually it's general pain that's deeper within the hip joint, right? So do your due diligence with those two because they can masquerade similarly. We've already kind of talked about this in depth, but generally speaking, if someone has FAI or they have some sort of hip dysplasia, they're going to present similarly and they can coexist. So someone may have CAM morphology as well as dysplasia together, right? And that's one of the patients I just talked about recently. She has borderline dysplasia, and she also has CAM morphology and a labral tear. So they did their due diligence to see if she had any sort of instability within the hip, and they decided the surgery for her was going to be a labral repair, not a PAO, right? So when they did the surgery, they repaired the labrum, they didn't do anything to the acetabulum, and they trimmed down that CAM morphology. So it's just important to know they kind of exist together. And what I will say, and we spoke about this before, is that that mechanism of injury might be a little different. So for FAI, those folks are typically hurting themselves in some sort of flexion rotation sport. For folks that have instability, they may be doing some flexion and rotation, but they may also injure themselves in sports that don't require any flexion or rotation, right? In that case, you may be thinking more dysplasia. It's also more common in sports that require a ton of range of motion at the hip. So think about your dancers, think about your ballet, right? Gymnasts. And these folks with CAM morphology are generally limited in hip flexion rotation. For folks that have dysplasia, they generally have a lot of range of motion at the hip. So those are kind of those differentiators between those two. The other one that can masquerade as hip dysplasia or hip labral pathology is osteonecrosis or avascular necrosis of the femoral head. They have very similar presentation. So I think the big one is if you're not making progress over a couple months, you send back the doctor. You need imaging to make a difference between the two to figure these things out, right? Could be dealing with some iliopsoas tendinitis, which is going to be very similar to tendinopathy. So same things, tenderness and palpation in a very specific spot, resisted testing, although they're going to be positive in both cases. Greater trochanteric bursitis can masquerade as hip dysplasia. Think about that stat we mentioned earlier on. 66% of patients that are undergoing surgery for hip dysplasia have a lateral hip pain, right? And most of these patients also have groin pain as well, but you might be dealing with a little bit of gluteal tendinopathy, greater trochanteric pain, or dysplasia, right? So just keep in mind the two can present similarly and sometimes coexist. I read a stat before, I think it's like an 80% carryover of folks that have labral pathology have gluteal tendinopathy. And one of my thoughts too is like, get older, you're more likely to have labral pathology, you're more likely to have tendinopathy as well. So it might be correlation, not causation. You might be looking at like an older beat up hip, right? So they can coexist as well. The other big one is going to be arthritis. So you have a patient that's over the age of 40, and we know hip dysplasia coexists with arthritis. So again, this is tough. Usually when folks have arthritis, they're starting to develop stiffness, and folks that have dysplasia are usually younger athletic females. And we know it's more common to have arthritis as we age. And what you might find is folks that are developing arthritis may be developing it because they had dysplasia, right? But as a primary diagnosis, arthritis is usually in advanced age patients and usually have more stiffness. They can also present with a snapping hip because folks with dysplasia oftentimes will have labral pathology, which we know they give mechanical symptoms as well. Usually snapping hip as a primary diagnosis is going to be every single repetition. It's oftentimes pain right over that psoas tendon. Sometimes it's visible, especially with a snapping hip on the side, right? But it could masquerade as dysplasia as well. The last one is lumbar radiculopathy. So for those folks, they're usually going to have positive dermatomal and myotomal symptoms, positive reflex issues, reflex changes left to right. Slump, straight raise is going to be positive. Before I let you talk, Kevin, I think the big takeaway is that there are many, many overlapping symptoms for all of these pathologies. And when in doubt, get it checked out. It's a good reason to refer, especially if you're not progressing. If someone's not making progress over the course of 3 months, you're going to want to refer out anyway, and then you're going to get some more answers at this point.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Any thoughts about all of this, Kevin?
Yeah, no, I think that was, pretty comprehensive list of differential diagnoses and things that we want to keep in mind as PTs, because, like you mentioned, we treat these things differently depending on what's going on. And I think that's a good rule of thumb for a lot of orthopedic issues is if you're not seeing the results you want, maybe go back to your differential diagnoses and figure out if there was something you might have missed. And if you can't figure that out, then that's a good time to refer as well. So, these things present fairly similarly, but I think you gave some good hints at different ways to hone in on one thing versus the other because there are nuances. So I think that was a good list, Dan.
All right. Lastly, let's get down to treatment. So what are treatment options for folks that have hip dysplasia? And we're going to briefly go over these just because we're going to do some future episodes where we go over non-operative as well as post-operative treatment. We'll get into these a little bit more. So A, you've got physical therapy. B, you have corticosteroid injections. And C, you have surgery. And the surgeries are going to be peri-acetabular osteotomy, derotation osteotomy. A lot of big words there. I'm definitely going to be messing these up. Hip labral repair and cam reduction. Let's go on. So From a physical therapy standpoint, this is a little sad, but there are no randomized controlled trials currently published looking at the effectiveness of physical therapy for hip dysplasia, right? So that's really unfortunate because we actually don't know if physical therapy is helpful for folks with hip dysplasia. There's currently a trial underway. It's called Move the Hip. And I think they started this trial in 2022 and it hasn't come out yet. Hopefully soon. It's a British medical journal, which is probably going to be a banger of a paper. So maybe when it does come out, we can review it and then see what they actually chose from an intervention standpoint and just hope to God that physical therapy was helpful, right? But we do have some recommendations. These are based on a Delphi statement, which we're going to be doing an episode on in the future. And essentially, what they recommend is activity limitation, therapeutic exercise, lumbopelvic control exercises, rehab of the hip flexor complex. And essentially, the hip flexors get really aggravated after someone has hip dysplasia, but the hip flexors are also extremely important. So basically, a period of unloading them followed by progressive loading is going to be important for these folks. Working on cardiovascular fitness, giving return to sport and activity specific exercises, and then referral back to a hip specialist. So essentially, it's going back to, does this patient have hip dysplasia? Let's treat them, see if they get better. If they're not improving, we send back to the surgeon to discuss surgical options. So if it's a borderline patient, maybe we're just thinking about a hip labral repair. And if it's more severe hip dysplasia, we're thinking more about doing a PAO procedure, right? We just chatted about corticosteroid injections. These are going to be helpful in the short term to reduce pain. Sometimes in a long term, it might be one of those things that can get folks over the hump. So if they're not making progress with physical therapy, we give them a steroid injection and keep up with the rehab. We may find that helps them over the course of time. What I will say is that I'm basing this off of research in an FAI population. I could not find any studies where they're looking at patients that had hip dysplasia treated with a corticosteroid injection. So take this all with a grain of salt. Not sure if it's helpful in patients that have hip dysplasia, but in patients that have hip labral pathology associated with FAI, it does seem to be beneficial. And lastly, we have our surgeries. So the big one is going to be a peri-acetabular osteotomy. The most popular PAO is going to be a Bernese PAO. I didn't look into the history of why it's called a Bernese PAO, but that's the popular one. And essentially, it's surgery for the pelvis. So when we're looking at FAI surgery, usually this is surgery on the other side of the joint where we're trying to do surgery on the femoral neck, reduce neck cam morphology, and the pincer surgery is on the pelvic side, but the PAO is going to be on the pelvis side, right? And essentially what they do is they correct undercoverage of the acetabulum. I have a better image in the next slide that you can see, but essentially what they do is they cut into the pelvis and they just bring the socket down so there's more overcoverage of the socket over the acetabulum, right? And you can correct the undercoverage in multiple directions, laterally, posteriorly, or anteriorly, right? The second surgery that you may see, usually in conjunction with the PAO, and it's much less common. I have never seen this surgery myself. And looking back on it, I wonder if I just didn't look at the post-operative report well enough for some of my earlier patients earlier in my career, and maybe I just missed these, right? You can get what's called a derotation osteotomy. And we talked previously about some patients having hip dysplasia because they have too much anteversion, antetorsion, right? You can do surgery to correct that on the femoral side. So essentially, you cut the femur and you change the amount of rotation, right? This is often done in conjunction with the PAO. Like I said, it's much less common, but what they're trying to do is reduce the amount of stress that goes on the hip due to having excessive anteversion, retroversion, antetorsion, or retrotorsion is the more appropriate word of the femur. So what are going to be the contraindications for a PAO? And the big one is going to be hip osteoarthritis. So essentially, if you have that patient that is diagnosed too late with hip dysplasia and they're starting to get arthritis, and we know the PAO is not going to go well. And that's why we need to get better at early diagnosis for these patients. The other one you'll see is age over 40 years old, right? And here's the thing, and this is the same thing that happened in cam and hip labral repair patients. We used to think that older age was the biggest reason not to perform these surgeries. And what we found over the course of time is that when you're older, there's a greater likelihood of having hip arthritis. And the reason why these patients don't do well is because we are doing surgery on patients with hip osteoarthritis. It just tends to be that older patients have more hip OA, right? The same thing happened in the PAO research. So essentially, we used to think that older patients are bad candidates for PAOs, but now we have more recent research to show that older patients are actually okay as long as they don't have a lot of hip osteoarthritis, which is good. And I've seen a couple patients now, a couple papers now that show the older age is not a contraindication as long as you don't have hip osteoarthritis, right? So the problem is that a lot of these folks already have hip osteoarthritis by the time that they get diagnosed accurately, and that's a problem, right? Now, what are indications for a PAO? So the big one is if you fail conservative treatment. So the current gold standard treatment is essentially trial physical therapy first. If it doesn't work, and essentially you're now going to be a candidate for surgery, right? And also having a lateral center edge angle that's going to be under 25 and more specifically under 20, right? So the borderline patients, oftentimes they're going to just get a normal labral repair. They're not going to get the PAO. But if you're under 20, then the PO is going to be indicated. And I know my surgeon friends, when they see a borderline patient, they're getting a little scared about performing that labral repair, right? And it makes the patient confused. They're like, why can't I just get my labrum repaired? But the surgeon's like, well, not sure how you're going to do because you do have that borderline, right? But I think we have more recent research to kind of help guide us a little bit. And I think we're getting better in terms of being more accurate with our diagnosis with microinstability. But again, it's a little risky for a doctor to perform a labral repair in a borderline patient, right? And here are some images that may help you out understand the procedure a little bit better. So if you're watching this on YouTube, you'll see it. If not, at some point, I recommend checking it out. So the image to the left, you got a picture of a pelvis, and essentially they cut through the pelvis right behind the acetabulum. And what they do is they bring the acetabulum down. And that creates more over coverage for those patients. In theory, you're creating more of that over coverage. And in the image on the right, you have all of the hardware, all the screws that screw the acetabulum in place after the surgery. And the bone kind of heals in afterwards. Usually with PAO, there's a pretty long period of non-weight bearing, so around 6 weeks or so, to allow things to heal well. In terms of treatment for those borderline patients that have dysplasia, you can consider just doing a cam reduction as well as the hip labral repair. Now, keep in mind, patients that have dysplasia, they often have cam morphology as well. So these folks tend to have 2 surgeries, and oftentimes it's 2 surgeons. So the first surgeon is going to do the PAO. The second surgeon goes back in and does a hip labral repair, and they also shave down that cam morphology. The PAO surgery is usually an open procedure, takes a long time. And then the cam reduction and labral repair is a shorter surgery done arthroscopically. And these take hours. It's a very long procedure. One of my buddies, like I said, who's a PAO doc, he says he just like blacks out for several hours, finishes the surgery, then afterwards just like wakes up. It's like a long, arduous procedure, right? So if you have a borderline patient, so hip dysplasia somewhere between 20 and 25, lateral center edge angle, right? Without hip instability, they're probably going to be a good candidate for just getting that labral repair and the cam reduction, right? And they are, I'm going to talk about a study in a minute. There are good outcomes for folks that have this, right? But I think the problem is that you're going to get some outliers that do poorly after they have a labral repair and borderline hip dysplasia. And the thought is, if we can be better about diagnosing patients that have borderline dysplasia and they have micro instability, right? So essentially they have poor over coverage and lax ligaments, then maybe we can better about figuring out which patients need the PAO and which patients can just get the repair. And the last thing before I move on here, essentially in folks that have borderline hip dysplasia, if they have their labrum repaired, we do have studies that show they generally have good outcomes and get back to sport. So the citation number 16, if you want more information on that, you can check that out. But those folks do tend to do well. How about borderline patients end up getting that PAO? we have a case series here. It's called Outcomes and Return to Sport Rates in Patients with Borderline Hip Dysplasia After PAO, a case series with 5-year follow-up. Now, keep in mind, this is not a randomized controlled trial, so we need more good research to check this out. But in folks that are borderline, and maybe they say they do have some microinstability and need to get that PAO, can they get back to sport well? This study looked at that. And it looks like, yes, the return to sport rate was 92%. And on average, it took folks around 6 months to get back. However, 35% of those folks reported a change in sport activity following surgery, meaning they got back to sport at a different level, right? And they were looking at high impact sports as well as low impact sports. And essentially, the high impact sports were things like tennis, soccer, volleyball, alpine skiing, mountaineering, running and jogging, dancing and martial arts. And then the low impact sports were cycling, long walks, Nordic walking, hiking, fitness training, swimming, yoga, and horseback riding. And essentially, I think they did find that they had a harder time getting back to the higher impact sports, an easier time getting back to low impact sports, which kind of speaks to the efficacy of the surgery, right? Essentially, if I have dysplasia and it's borderline, I don't know if I want to go and do the surgery if I don't know it's going to give me a good outcome. I'm going to try conservative rehab as much as I possibly can, and maybe just consider getting a labral repair because I may be able to get back to my sport a little bit easier than getting the full PAO, right? And that's why we need more, better studies to help guide our patients a little bit better. But lastly, at least in this study, for the folks that had to change their sport activity, it was for mixed reasons. So it wasn't necessarily because the rehab didn't go well. It was also because a lot of these folks just didn't want to get back to the same level of sport. And lastly, what about PAO for patients that have all forms of hip dysplasia? The last one was just in borderline. How about folks that have borderline as well as folks that have less than 20 lateral center edge angle? And this was with Dr. Hayworth, who's a local doc, and Dr. Novias, which is my local friend that does PAO surgeries. So pretty cool to see your friends doing research in the area. I actually wasn't aware that they did this paper. So essentially, this paper is called Return to Play After PAO for Treatment of Acetabular Dysplasia in Adolescent and Young Adult Athletes, published in 2016, American Journal of Sports Medicine. And they found a return rate of 80%, which is pretty dang good. And their average return was at 9 months, so a little bit later than the previous study. But what I will say is that if I'm looking at my PAO Rolodex of patients I've worked with in the past compared to my FAI post-surgical patients, the PAOs take significantly longer. It's more arduous. There's a longer period of weight bearing. I think they're more irritable. I've just seen patients take quite a bit longer with that PAO compared to the FAI surgery, right? And 73% of patients return to the same level of function. And that's one of the reasons why I wanted to report on this study. There are more recent studies looking at return to sport rates, which are all pretty dang good, but not many that are reporting at returning to sport at the same level, right? The other thing they mentioned is that 89% of recreational athletes return at the same level, whereas only 58% of competitive athletes return at the same level. In my opinion, this is a big problem because if you have, let's say, an elite level athlete that needs to return back to an elite level of play, it might be harder for that athlete, right? Which kind of goes back to the prior study on borderline patients. So those borderline patients had a harder time returning back to elite sports, right, compared to recreational sports. And that's the same thing that this study is showing. So unfortunately, that stinks because if you have a patient that has hip dysplasia and you want to give them a PAO, oh gosh, that's a 50%, flip of the coin. Are they going to be able to get back at the same level of function? So two things. A lot of patients, they might just end up needing it, right? If they fail conservative treatment, they might just end up needing it. But the other piece is that if I have a patient, I may be trialing physical therapy for a little bit longer, right, to see if they can get back. And if they can't, I'm obviously going to recommend that PAO. But at the end of the day, it almost seems like we don't have the best options for these patients, unfortunately. Any thoughts on all that? That was a lot of data to take in, Gavin.
Yeah. I think what you said at the end there was what I was thinking is that, surgery is an option that will probably improve pain. It might improve function with daily living type stuff. It would be good to look at these studies a little bit more in depth and just see, for what reasons were they potentially not getting back to competitive sport. But I would echo what you said, maybe this is someone who we do a longer course of rehab with to try to prevent the surgery. And it kind of, again, makes me think of the shoulder in a way where some of these more advanced stabilization surgeries where we're trying to reduce instability. It's just hard when these sports require a lot of range of motion um, to get back to prior level of athleticism and competitiveness. You can picture like gymnasts or dancers that require so much range of motion at their hip. This procedure might improve their hip joint health, but it may not lend to high level performance if they can't do the same things at the same level of function. So I think the way you outlined it with, physical therapy first, maybe followed by a corticosteroid injection that might either help with symptoms or diagnosis. And then if you're still not having the success you want, there are surgical options which are good. And, I guess unless you're going to be professional, you have to think long term, how long do you want to push through this? And we know, like you said, if you do start getting more advanced osteoarthritis, you're not going to have a great outcome with some of these surgeries. So, it's something that's really good to know from a PT perspective is, how far can we push this non-operatively? And if you are developing arthritis, when do we pull the trigger on a surgery to make sure you're still a candidate for this? So I think a lot of good things to consider. But I think you laid it out pretty nicely for, a good treatment outline.
Yeah, kind of like the thing that's tough is that like this is like very poorly researched compared to other types of pathologies. But I remember essentially when I first started working at Champion, right? And just to give a little context, before I worked in a standard outpatient setting with more general population, some athletes, and I moved to Champion, which we're working with like a ton of professional baseball players, right? And you have Mike and Lenny who worked for decades in professional sports. And I remember biceps tenodesis. Biceps tenodesis, one of those things was like, oh, really good outcomes. I see it all the time. Looks like the research is pretty good about it. But if you look at biceps tenodesis in professional baseball players, the return to sport at the same level of play is not good, right? And if you're working with an elite athlete and you're like, oh, biceps tenodesis is a great surgery, like maybe for the average person, but not necessarily for an elite athlete. So what we do at Champion is we just basically rehab them for longer and see if we can get away with more non-op rehab because we don't want to potentially end their career by getting the wrong surgery, And my thought is, I don't know, if you work with a lot of, let's say, ballet or gymnasts, and I think talking to Dave Tilley, who's our colleague, who works with a ton of gymnasts, might be a good person to ask this question, is that maybe we're thinking, let's treat this for conservatively a little longer and maybe hold off on that surgery a little longer unless we absolutely need it because we're fearful that folks won't have the best outcome. But what I will say is that, again, going back to my Rolodex, I can think of a few, I would say collegiate athletes. I'm thinking of a baseball players and a few other, a baseball pitcher and a few other athletes that have gotten PAO and they've gotten back to playing sport at the level that they wanted to. And I'd love to be able to call them right now and just say, like, how are things going? Like, what were the struggles afterwards? Maybe we should at some point. But I've seen some folks do well with it. So it's bad to say that it's not a good surgery, right? It's just that I think that on average, you just have to just keep in mind that, it's a bit of a coin flip. You might do well, you might not. And maybe being a little more conservative may help. And my secondary thought is like, we know the standard of care is not great for most, sports rehab. So if you had a really, really good program, which maybe future studies will show, maybe the return to sport rates jump up a little bit. Maybe that the return to sport at the same level of play jumps up a little bit. Who knows, right? So a lot of questions. We always need more research, right? That's the theme. But yeah, I had a great time with this one. I learned a ton, and I think it's going to make me a better clinician. All right, so now you know all about hip dysplasia, but you could be dealing with a patient that has femoral acetabular impingement. And in fact, you're probably dealing with someone with femoral acetabular impingement because it's a little bit more common. We have the video for you. It's going to be existing, not that way over top of Kevin Coughlin's head. We go over what physical therapists need to know about femoral acetabular impingement. Click on that link and I'll see you there.